Thanks for that. I was just wondering if there are any activities underway in any of the states to do outreach public education to ameliorate some of the public's concerns, many of which I think are grounded in mythology and bad information, but that's an editorial comment. I'm just wondering whether there are any efforts underway to try to head off those concerns before we take on expansion of any of these programs or introduce something like whole genome screening for all babies.
So that's a good question, Joe, about states, what states are doing to better inform the public about various elements of newborn screening, positives as well as the storage of samples. So the answer is yes, and I'm not from a state, so I can't speak to that, and there are others who may be better equipped, but I do know that some states are starting to increase the information that parents receive at the time of screening, so that talking about a sample, that there will be a sample. And I don't know if states, I think some states, but I can't remember which ones, have an opt-out, so at the time of screening, patients can, at the time of sample collection, parents can check opt-out that they don't want their sample to be saved. But I don't know what states, or I don't know if anybody else wants to address that. Thank you.
Also, when you're asking a question or commenting, please introduce yourself.
I'm Carol Johnson from the Iowa Newborn Screening Program, and I have Kim Piper beside me from the Iowa Department of Public Health, and Stan Burbrick is over there from our lab. So this is, I think, one of the most important things that we can do in newborn screening right now is to start educating not only PCPs and allied health, but parents. So it's a monumental task. What we are starting in Iowa is we have, and it's only with one group at one hospital right now, but we are doing prenatal education about newborn screening while they're a captive audience, while they're there for their medical appointment. And we talk about newborn screening. We talk about what's coming in the future. We talk about opting in, opting out. We talk about dry blood spot retention, and we talk about research. So we're starting the talk, but I'm saying it's one place, one group, and there's a long way to go.
Thank you.
Thank you. And to add to that, I know that there are a number of states that are doing a number of different activities around education, and we as the Baby's First Test, really thinking about how do we help engage that type of education at the state level and also nationally. And it's through videos, but a lot of it is one-on-one, and that's very hard to try to see how do you actually have a conversation. A brochure can be a good start, but a lot of parents want to have the conversation and want to be able to ask the questions.
Good morning, everybody. I'm Mark McCann, Program Manager for the State of Minnesota's Newborn Screening Program. Over 7 or 8 years back, we conceived the idea to greatly educate and impact the parents of Minnesota in large response to what we were faced with, which was then a political challenge regarding this whole push of privacy, absolutism, and personal autonomy. And present day, so over this period, we've actually functionalized a operations group within our program. I've got 6 FTEs, in large part devoted to public health education. We have sustainable prenatal education, general education, and in the hospital nursery-based settings and midwifery community, in the home birth community, we've had real impact as well. But it's not been enough. It's been amazing to see this journey in terms of educating parents about, risks and benefits of newborn screening with this onslaught of getting caught, in the crossfire of personal autonomy and privacy absolutism and really ground zero for, genetic privacy kind of issues. Through this process, we've gotten a lot smarter, of course, when it comes to data practices, when it comes to public health education. But even with a concerted effort and putting resources in place, it's seemingly not enough. I'm really proud of many of the parental advocacy groups as well as the APHL, ACMG, on many levels, people have really come alive over the last few years to help with that general kind of marketing push for public health newborn screening programs. And I'm glad to see that. I think the future will be much better when it comes to, I guess, self-promotion, and that there is benefit from doing these kind of activities.
Can I just ask you, thank you, do you have a check off about, on the form for parents, whether they want the sample to be retained or not?
Presently, no. We do not have that operationalized. We're still amidst a very long legal battle in Minnesota until the dust settles on that. I mean, we're 5 years into a lawsuit that went from district court, appeals court, Minnesota Supreme Court ruling, a lot of unintended consequences, now back down to the district court. And I fully expect almost a full circle again back up to the Minnesota Supreme Court when this is all over. But not yet.
Great. We'll take one more comment, but I also wanted to mention in terms of education that, and Mark, you briefly mentioned this, APHL and CDC and a number of other stakeholders are engaged in celebrating the 50 years of newborn screening, which is being celebrated this year, and that's 50 years of state-mandated screening, and through a newborn screening awareness campaign. And so there's a number of different activities going along with that. And though it is to commemorate the 50 years, it's not going to end this year. It's really kind of a way for us all to come together and to do that broad-based education that's so needed. But one more comment, and then we will move on.
Lynn Bush, Columbia University. Just wanted to say, historically, this very question that Nancy raised was raised 50 years ago by Ruth Faden, saying that, and in the PKU anxiety syndrome, that if there was proper education for parents, adequate information, some information, including opt-outs and such, there would be far less anxiety, including over false positives, which if parents were aware and pediatricians were aware that there are, the majority of false positives are just that, the majority of initial positive screens are just that, as false positives. That could really go a long way to help it. But it's really an old issue that the time has really come for it to be addressed right away.
Great, thank you. And I know a number of people in this room have worked on different types of research, again, showing that having that initial conversation would be so helpful. And I think it's also important to point out that this is an issue in public health throughout. It isn't just a newborn screening issue that, how do we reach people? How do we educate them? And then when you're talking about something as complex as genetics, it just makes it that much more difficult. But thank you.
Thanks for your talk. I thought it was interesting, your survey of moms for adult onset conditions, and I was wondering a couple of things about that. So one is, if you're talking to these moms and giving them the possibility of screening for adult onset conditions, did you explain to them that you're not necessarily going to say yes, they're going to develop cancer, or yes, they're going to develop heart disease, but you're going to be giving them a risk, and they may or may not understand what the chance is that they may develop cancer, they may develop heart disease, because I think a lot of the conditions that are on the screen now are much more, you do have this based on based on these results. And then the same thing with those conditions, and even things like celiac, I worry sometimes about what that result that says you're not at risk might do, especially because we don't know what all the genes do yet. And as we go into whole genome and whole exome, we're going to be learning more and more. And so do you worry that if something like that was on the screen where people would say, oh, well, I've been screened for cancer, so I'm not at risk anymore?
Yeah, I think when you consider adding something, I think, especially when you consider broadening to outside of, the diseases and the kinds of diseases that wound up on the initial list, which were the right ones. I think the first thing you've got to think about is safety and how much you screw people up. And, and I think there's a lot of, I'm not suggesting, for example, that celiac has no risk. I just thought it might be an example of, a diagnostic, maybe a diagnostic that you could use. Are there other consequences? Quite possibly. And then with the understanding stuff, I don't recall how explicitly we explained it, but I think there's a bit of it, at least implicit in the sort of, in the question where it says, we're talking about things that might develop later in life. So, but I don't think we really got into sort of penetrance and risk, and it's a good question.
Sorry, I'm Carrie Bloud at Johns Hopkins.
Okay, Perry Thompson at the American College of Medical Genetics. I thank you for an interesting and it never hurts to be provocative. I do think that it brought back one thing to us when you do a survey such as this, and it's a real problem for clinicians and for counselors, as we all know, but it's something that we haven't solved with education. When you ask the parent, recent or prospective, about the tests that they'd like to have done for their child, it'd be interesting to match that to how they feel about having those same tests done for themselves and how they would handle the difficulties that are more proximate for themselves at that point in time. And just another one of those issues that we have to deal with that we haven't solved as far as education is concerned.
I agree completely. In an older study about research participation, we asked people whether they'd want to get their results back for their kids and whether they'd want to get them back for themselves. Kids unequivocally, yes, absolutely, you must give me everything about my child. Myself, still a lot of interest, but
a little short, so I gotta. Aaron Goldenberg from Case Western. I just had a quick comment and then a question to follow up, which is that your list of kind of current accepted criteria or current criteria that are used to make determinations. I think one of the things that we need to be careful about today is the fact that a lot of those criteria that are on the list are not settled criteria for now adding one or two conditions without even thinking about genomics. So familial benefits, society benefits. So one of the, I think the questions for us today is to talk about how you might take some of those potential questions and deal with them both on a general level for adding a particular condition, but then also what does that mean when you start thinking about genomic screening, right? And I think that that's going to be just, it's a challenge for us to think about the fact that that's something that will transcend both the move towards genomics, but also just is something that's unsettled today, and many programs struggle with that.
So Aaron, that's kind of digging right in there, right?
Right,
For
sorry.
today. No, which is good. We shouldn't hold back. And, you know, we've all had these discussions, I think, about setting. So should the setting be screening, newborn screening at public health level? Should it be at the provider's office, since now everyone will have a provider? Right, that's, I think, that's part of the gray zone that, yeah.
Yeah, no, I think so too. And David, just very quickly, you said something in your list when you, after the two criteria, you had a list and you said low risks of harm. And I'd just be curious, just in your take on this, what do you consider those harms? What are the harms that you're thinking about when you say we want low risk of harms? Thank you.
I mean, I think, you know, there's the anxiety, there's the not adding to the sort of serious false positive, you know, the sort of immediate effects of the test. I mean, I guess I was thinking more concretely about, you know, not directing patients to treatments that may be harmful, you know, that are unnecessary. I mean, you know, it's the sort of first one that comes to my mind, because I mean, it's a reason that some conditions haven't, you know, some conditions on that list haven't been, you know, put on the main list for that reason. I mean, again, I'm not a clinician. I don't pretend to be able to rattle off, you know, which ones are the worst, but I think it's pretty important. You know, just not adding things willy-nilly because you can. You got to look at them.
Martha Maria Knopper, Center of Genomics and Policy, McGill University. I was a bit surprised that following Nancy's talk that the questions, or perhaps it was just the way your questions were phrased, that the particular public health programmatic setting for these questions was not sort of like a preamble before asking, you know, individual mothers what they want, sort of, or what does direct consumer offer you, what do you want your doctor to offer you, but to emphasize that answers to questions can also differ when you say, if it's in the public health, it'll be, your answer will mean every newborn would get it if you pay for it, and if you consider this to be a public health priority for all children. And I think if we lose that sort of setting that is particular to newborn screening, then of course we're going to get consumeristic kind of answers.
I think that's a really good point.
Ellen Clayton from Vanderbilt, and I have a follow-on to Bartha, which is that wouldn't an alternative be for the children who have undiagnosed disorders as be what we're increasingly seeing in our clinical practice, which is that genomic approaches to diagnosis are taken, earlier rather than later. And so, one question that I think we need to think about with regard to newborn screening is this is not the only time this child is ever going to be seen in the history of the universe. And there may be other alternatives. I mean, we screen for all kinds of stuff across the life course. And so one of the factors that I think needs to be taken into account is this the right time? So that's just a follow-on to Bartha.
And not only the right time, Ellen, but the right resource allocation.
Yeah, that makes good sense, Ellen. I mean, the parent's going to go and get a genetic test, maybe they get a genomic test. Yeah, but that doesn't mean you have to do it for everyone born in this morning.